Welcome and thanks for having me. Today I want to make a simple argument. Qualitative methods aren't a sort of soft add-on to implementation research. They're often the part that explains why an intervention works or fails in the real world. I'm going to use tuberculosis as our kind of running example throughout this lecture because TB is almost a perfect case study of the gap between what we know and what we actually deliver in the field. I will be briefly talking about a set of qualitative tools that you may have at your disposal. My goal is to show you how it maps onto implementation questions. So, hello everyone. My name is Dr. Arman Majidulla. I'm an assistant scientist in the Social and Behavioral Interventions program in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. So here's where we're headed. First, I'll define implementation science and the no-do gap quickly. That's the framing, and I'm keeping it short on purpose. Then we'll spend most of our time on the qualitative methods themselves, how interviews, focus groups, and observation get applied to implementation problems, and how sampling, timing, analysis, and reflexivity shift in this context. Every concept that I'm going to bring up here is going to be framed within a TB example. TB was and is my area of research and my preferred go-to anytime I give a lecture of this kind. So bear with me. The thing I want you to leave most with is to have a brief overview of this intersection between qualitative work and implementation science. So implementation science studies how we move proven interventions into routine practice. The key insight is that the bottleneck is usually not the science itself, it's delivery that is messy in real world systems. When we're actually taking a concept that we came up with in the halls of academia or in a lab somewhere, applying it in the real world is really where things become a little bit complex and challenging. TB is kind of a textbook case. We've been able to cure it for over a half century. We have effective regimens, as many of you know. We also have rapid molecular diagnostics and digital tools to support adherence, like GeneXpert, many of you already might be familiar with. And yet, uptake and treatment completion still fall short all along the care cascade. So the interesting questions aren't, does the drug work? They're about people, clinics, and systems. One more distinction that matters is that implementation cares about implementation outcomes, okay? Things like adoption and fatality, which are completely different from health outcomes like cure or reduction in CD4 cell count, especially if you're studying or caring for folks with HIV, or a reduction in your hemoglobin A1C score, for example. Here in this slide, we have a brief overview of the framework landscape and is kind of the core implementation science context that I wanted to give you before we get into the methods. So briefly, CFIR in the first column explains context. It's a checklist of what's going on around an intervention. It's organized into 5 distinct domains. You can read the 5 domains here. Re-aim in the second middle column is an evaluation lens. It asks who you reached, whether it worked, who adopted it, whether it was delivered as intended, and whether it lasted. Proctor's outcomes, or the last column on this slide, defines what to measure: acceptability, feasibility, fidelity, and so on. Notice that those Proctor outcomes are mostly about perceptions and experiences, which is exactly where qualitative methods shine. On that note, we know that quantitative methods tell us whether something worked and by how much it worked. It's a count, a survey, a census, an examination of numerical information, typically. Qualitative methods tell us why and how. So those frameworks I just showed you are empty boxes until you fill them in with real context. The qualitative inquiry is how you would do that. It's especially powerful for understanding barriers and facilitators for explaining a disappointing result, why a proven intervention underperformed in a specific place, and for surfacing what patients and providers actually value in their everyday worlds, which is often not what we assumed when we design some of these interventions. And in practice, most implementation research is mixed methods by design. That is a combination of qualitative and quantitative pieces planned deliberately to answer different parts of the same question. So that's the framing. Now we're going to spend the bulk of our time on the methods themselves. Everything from here is qualitative methods applied to implementation, and I'm going to again be couching this all within some TB examples throughout. So before we go on to talking about methods, I want to take a second to give you an organizing framework for conceptualizing qualitative work. Here I present Crotty's framework, which is sort of a useful framework in that way. I'm not going to go into detail into each one of the points listed in each one of these columns. I would encourage you to go and explore this reference from Crotty on your own. But the main takeaway from this slide is that epistemology, or your perspective on how knowledge is constructed, whether that's objectivist, i.e., there is a absolute truth that exists out there, whether it's constructivism, which is that a true meaning is given through interaction and created through interaction, or subjectivist, that any meaning is subjective within the person and is determined by the person, sort of gives you an idea through which you might pick your theoretical perspective, or a theoretical perspective might apply in your context. You can see a few examples of theoretical perspectives here, of positivism, interpretivism, feminism, critical race theory. These are all very useful theoretical perspectives. In the past, I have used mistrust or trust as a theoretical, trust in healthcare as a theoretical perspective as well, which then in turn informs the type of methodology you would pick. So what do we mean by methodologies? There are several of them listed here. This is by no means a complete list of methodologies, but some methodologies would include ethnography, which is, deep study of cultures and interactions and social relationships and how they give shape to other things, phenomenology, or specific events that occur in an individual's life that you're looking to study, a phenomenon of interest. Narrative research or case study research. Specific examples that I'm reminded of are Zora Neale Hurston's book on the lost African slave to enter the US. Is a fantastic book and recommended for those of you who are interested. Follows the case of one individual and really is a good exemplar of a methodology that's a case study. Or you could equally have grounded theory as your methodology. Now, all of these methodological perspectives then inform your methods. For example, if we were to do an ethnography, which is trying to understand the culture surrounding a certain set of social relationships that is of interest to you, that might be, that you're interested in how government bureaucracies work around health, in specific how decisions are made, and how culture within those spaces is formed. You could imagine needing to rely on a few different ways through which you would collect information about those relationships. And the methods column provides you a list of those types of methods. And we're going to go into this in a little bit more detail. So again, I highly encourage you, if you're interested in this, to please do go ahead and find the reference for Crotty's framework, and then go into more depth through that work that Crotty put together. So implementation work is problem driven. So pragmatism is often used as an epistemological view. Pragmatism, you could always almost think about it as a combining of two epistemological paradigms, like your objectivism and your constructivism. Is to say that there are some absolute truths out there, but then there are also some truths that might be socially constructed or constructed within relations, within amongst others. And methods are often chosen to kind of fit those types of questions. And in the case of pragmatism, that often involves mixing both qualitative and quantitative methods to be able to get those relevant truths. Rigor still depends on an explicit epistemology. For example, we've been talking about objectivism and constructivism. For objectivism, it's equivalent of saying, have we been able to unbias this work effectively enough to get the quote unquote truth such that it could be generalized? For constructivism, we ask the question, is the true thing we're describing credible? Is it dependable and transferable? And I'll talk a little bit more about this a little later in this talk. Another thing I wanted to say is that constructivism and critical lenses matter for equity. It is really for equity questions whose definition of a successful 3B program counts as one of those questions. The funders, is it the clinic's definition of it? Is it the patient's definition? How do also stigma and power shape who actually completes treatment? Those are not necessarily pragmatic questions, but they're critical ones. There are three primary methods that we'll be discussing in this course. And there are three primary methods that sort of most qualitative work will end up using. The first is sort of in-depth interviews. These are kind of the workhorse primary method. They're giving you depth on individual experiences. Focus groups are really useful, but they're often over-relied upon. They're best for kind of understanding shared norms and social dynamics, but they really shouldn't be thought of as multiple in-depth interviews all combined into one because you have five people in a room as opposed to just one person in the room. That's really not what the purpose of focus groups are. They don't necessarily get you more information, but they get you a different kind of information to the ones that you would get if you were just doing in-depth interviews alone. And those are your shared understandings of social dynamics between peer groups. Observation is often underused and has a lot to offer because it shows what people actually do, not just what they say they do. And so, for example, you might be in an interview and a given participant in your interview is describing the procedures that they undertake at a TB clinic. They might be saying, yes, yes, of course, we, ask patients to wear masks and to double mask, essentially. Everyone in the clinic is double masked to mitigate potential spread of TB within these very confined spaces. But we don't really know if this is happening. All we have to go on in an in-depth interview is the word of the participant. So what we could do is we could go and we could go to the clinic and observe what is actually happening there. Are patients being directed to wear masks in the way that the maybe porter or the clinician that you spoke to has said that they were? Or is the truth of the matter that it lies somewhere in between, that something else is happening in the clinic? Observation is one of those ways in which you could actually get that information and not rely on just the spoken narrative of a given participant in the project as the ultimate way of knowing what happens. And documents and record review are also used, but they're almost always paired with quantitative data. The discipline I want to plant here is that the method you choose depends on your implementation question, not the one that you're most comfortable with. So pick your methods based on what it is that you're looking for. For example, I gave you an example of understanding infectious dynamics within a clinic setting, within a given place. You would want to use observation in that case alongside in-depth interviews. But if your question is more understanding how patients may not be adhering to treatment because there might be some social stigma that is manifesting through the course of clinical care, that is something that you might want to use focus groups to get at, or again, in-depth interviews and observations likewise have a lot of value in that space. Now, let's talk about each method in turn. We're going to start with the with interviews. They're the best when you want individual perspectives. We spoke about the clinician or the clinical manager in the prior slide. And in implementation, that means a wide cast of characters would be relevant to you. For example, in addition to clinicians or managers, you might have patients or frontline providers or policymakers that are useful, particularly to interview. Semi-structured guides will give you consistency across interviews while leaving room to follow where the participant leads. So the distinctive implementation move is to probe the gap between policy and practice. What the guys say is versus what people actually do on a Tuesday afternoon. And because implementation is multi-level, you interview across levels to triangulate a single question. The district officer, the nurse, and the patient all may describe the same problem in completely different terms. So interviews are usually the backbone of an implementation evaluation in this particular case. Here's what that looks like in practice. This is the 99 dots digital adherence work that happened in Uganda. You will see the reference for this below. I recommend that you check it out if you have any interest in this space. 99 dots was a low cost approach where the packaging pill or the pill packaging reveals a hidden phone number each day that the patients call to confirm that they took a dose. The team did an in-depth interview with the patients and other key informant interviews with health workers across 18 facilities, with a guide informed by the COM-B behavior model. The COM-B model is just think of it as a framework. It's a framework often used by behavioralists in different spaces. It's a very common and very famous framework that is used. What did the interviews reveal that the dashboards couldn't? That's something as basic as phone access and network coverage shaped whether the tool worked at all. That provider follow-up was decisive, that patients actually valued the privacy and fewer clinical trips. And crucially, that staff had developed workarounds completely invisible in the routine data. The last point is a whole argument for qualitative work in one example. So, on to focus groups. We use them when the social dimension of your research is sort of the point of your research. If you're interested in things like shared norms between people, shared values, social influences that might exist across a group, or a range of views in a community, they're great for adapting messaging before you roll something out, and the group setting can surface stigma that an individual themselves might not name directly in conversation. A limitation, though, on that note, is that they're not really the best place for sensitive or individual level disclosures that might happen. For that, you still want to conduct private interviews to be able to gain that type of information. Now, sensitivities around sexual partners, sensitivities around TB status, particularly in settings where having a TB status might be disqualifying for certain individuals. We know this from COVID-19 that early on in the pandemic, somebody in your family or friend group or a relative or someone, an acquaintance that you might know, them having TB or sorry, having COVID-19 was a stigmatizing factor. And when we're talking to people about the influence that their diagnosis with COVID-19 had on their family dynamic, revealed some, private things that they would not have wanted to talk about in a focus group setting, or rather wanted to talk about it in a private interview setting. Now, turning to the TB example that we've been using so far, if you could imagine focus groups being conducted with TB, HIV co-infected patients regarding something like mixed doses or exploring people's missed doses, pardon me. Something that might come out of these focus group discussions are collections of facilitators and barriers, for example. Some facilitators might be that the belief that TB is curable, that they could have, they could seek care and the care would work. or that family and provider support is really important for them in order to avoid missing doses. And some barriers that might emerge from these discussions is things like side effects from the pills that they're taking, or the burden of taking pills, the frequency and the volume that they're taking, food insecurities that they may have, or stigmas that might occur. And running separate focus groups, for example, between different groups. So we've been talking about focus groups with patients. If we discuss or organize a provider focus group or a focus group with providers, this might expose a whole different set of things like workflow issues or supervision constraints on the delivery side. It might have been tough for them to organize, or providers to organize the right kind of management around disbursement of pills, particularly in certain settings where pills are provided for free or nutritional supplements are provided for free. These group settings might expose some of those dynamics. Now we talk about direct observation. As I mentioned before, direct observation is kind of often underused, and it's sort of my personal favorite for implementation because it reveals the gap between what people report and what actually happens. It's I think of it as the ideal method for studying fidelity. Was the intervention delivered the way it was designed? You might, in that case, want to capture things like workflow, wait times, and informal workarounds that people have but don't often talk about them. And one of the best ways to do that is to go and observe the work that's happening. Go observe the clinic, go observe the home setting, depending on your question. The type of observation you do ranges from full participant observation, where you are both participant and observer, because you cannot have your role as a person functioning in a setting being excluded from that setting, to sort of a quick structured spot check. You go in and you have a form, and you quickly make an observation of the things that you see, and you note it down on your form, and that's all you do. So participant observation might be that you go and you sit amongst the patients and you try to understand the workflow from their perspective. Or you sit amongst the providers and you just observe kind of the flow of work in a given clinic. Now I'm using a TB clinic as an example. So going into that example, directly observed therapy is sort of in the name, right? You observe it. So what do you want to see? Does the provider actually watch the patient swallow? So I, as somebody who's doing participant or direct observation in these settings, would want to see that. Is the provider actually watching the patient swallow? Or has that quietly gone away? Do they not quite watch the patient swallow? They just assume that the patient's going to swallow, but maybe 3 out of 10 times the patient doesn't. They take the pills and they might say, oh, I'm going to take it for later, and the provider doesn't notice. You might want to do things like map the clinic flow from registration desk all the way to the drug pickup window, define any bottlenecks. So when the patient is going from point to point between these settings, in this particular setting, if it's, for example, a specialty TB clinic, or if it's a hospital setting or another outpatient setting, observing the flow of the patient can often be a very useful endeavor and reveals many things. You also want to note where the reminder calls or pillbox logging breakdowns are, and then compare what you've observed against what the staff told you in interviews. The discrepancies are often what we're really looking for in these. So that tension between what is said and what is actually happening in reality is what we're really looking for in this using this type of method. Sampling in implementation research follows sort of the same logic that we're talking about. You want to have purposive cases or rich information cases and not representative cases. So we want rich information and not a random sample. What's distinctive is that we sample the whole system, not just patients. Patients and caregivers for lived experience, might be sampled. Frontline providers might be sampled to understand how delivery actually happens. And managers and policymakers might be sampled for understanding how resourcing is done and how resources are allocated and scale up what that looks like. Two strategies are particularly useful in this scenario. One is a maximum variation strategy, where you deliberately include sites that are succeeding, that some, for example, we take TB, for example, there are some TB specialty clinics that are doing really well, and there is a lot of treatment adherence. And then you go to another site and you might notice the opposite happening. It's not doing that well. Or some other site that lives somewhere in the middle. And really that's what maximum variation can get you, is that what it will get you is the differences between these. But what you get is a lot of richness throughout this process. And snowball sampling is often used to reach people who are hard to find, but essential to understand what is happening in your particular study or in the context that you've chosen. So take TB, for example. An obvious example is that patients who were lost to follow-up. These are not patients that are coming to your clinic. These are not patients that are coming to your outpatient setting. You want to go and find them. You want to find them through others in your community, maybe through the community health workers that you're working with, or through others that might be able to point you towards informants who are lost to follow-up. If that's the kind of study that you're interested in, this snowball sampling approach is a very valuable kind of strategy to use in that particular moment. So in this slide, we're just going to now tie the framework to an interview guide. Think of it as the practical, how do we do it? That is, when you're thinking about, well, okay, you've talked about a lot of this, but what does it actually look like? What does it look like to do this kind of research? So for this example, I'm going to use a framework like CIFAR, and the thing that CIFAR provides is structure to your guide. It doesn't script your conversation, but it provides you some general framing for the range of questions that you can ask in your interview. So, for example, let's talk about the TB digital adherence study. At the interventional level within the CIFAR framework, you might have a question that says, walk me through using the pill box on a normal day. Then moving down into the inner setting within the CIFAR framework, you might ask a question to get at that inner setting that says something like, how does this fit your clinic's routine? Then moving into like the individual level of the CIFAR framework, you might have a question like, what do patients tell you about taking TB drugs? And finally, in the process level of the CIFAR framework, you might ask a question like, who made this happen here and who didn't? Keeping questions open is vital. You will have noticed that we asked what questions, we asked how questions, who questions, a walk me through a journey question, as they're called. It allows respondents and participants to fully explore and express their views on a particular matter and moves away from closed-ended questions that might elicit a yes-no response. For example, you might take the inner setting. How does this fit your clinic's routine? In this question, we ask the how, which a participant might answer at length. But you could easily imagine this becoming a closed-ended question if you just swapped around a few words. For example, in the inner setting, you could swap around a few words and change it to, does this often fit your clinic's routine? And one of the responses you might get is no or yes. So it's really important to remember the starting point of these questions and what these questions are trying to elicit. What, how, who, and journey questions are often really helpful to elicit open, detailed responses. You're coding deductively and inductively at the same time, and we'll come back to that in the analysis side. So remember that these framings or these mappings in the framework are helpful, and we are going to touch on that in a little bit. One thing that surprises people coming from traditional research is that implementation work in implementation work, qualitative data collection is spread across the whole study. It's not just sort of tacked on right at the end of the study. It can exist over 3 phases, generally speaking. As you can all imagine, this is fairly intuitive. You have the formative phase, which is before or really early in the study. Here, you're trying to understand context, and the adapting of the intervention, the adapting of your guides. For TB, for example, you'd scope, stigma, and phone access before designing the rollout. And the process, which is sort of the middle, it's while the intervention or the program is occurring, or it's going to sort of during, you're monitoring how delivery is unfolding in real time, how it's unfolding as practiced. You might feed back findings in real time. You might feed them to a dashboard. You might collect this for publication, etc. And in the TB world, how would you do this? You would do rapid interviews, then flag anything as reminders for what's not happening, for example. And you can still fix these as you're doing some of this work in the process. And lastly, you come across that you can conclude with the summative. This is the type of qualitative work that would happen after the intervention or the program is concluded. You would explain the outcomes that you're seeing in the program, assess any sustainability and the spread. I think back to a cook stove project that I was reading recently. They did an evaluation of the program at the end of the program to understand how adherence worked throughout the program, what led to high levels of adherence of using clean cook stoves in a particular setting. So it's one sort of example, but taking it back to the TB example, you might want to, this type of evaluation might give you information about why completion rose in some clinics, but not others. So those are things that this is an important piece of understanding qualitative work in the implementation space. On analysis, framework analysis is sort of the workhorse in this field. You kind of, in this type of analysis, map your coded data onto a matrix of constructs. These are often kind of concepts that might come from either the framework that you use, that's for example CIFR or REAIM, or they might come out from the interviews and focus group discussions, observations inductively. We use the word inductive to describe anything that emerges from the data itself. These are emergent themes, as I mentioned. And as mentioned, using framework analysis can produce some rapid results. One of the issues that often emerges when folks use framework analyses or matrix analyses, as they're called, is that you're trading depth. That is, people have spoken to you for 45 minutes to an hour, something like that, and they've said a lot and they've provided lots of detailed responses. You can't often get a lot of that detail into a framework. But this particular approach is useful when you need to make rapid decisions. And within this space, a really useful output is a construct by site matrix. This sort of, you would imagine this as an Excel sheet or some sort of spreadsheet. You would have down the rows, you would have your constructs. So if you take your CIFR, for example, you might have individual, you might have your intervention, process, etc. Each of one of those constructs within the rows, and across the columns, you might have your sites. So you might have one clinic site in one location in an urban setting. You might have another clinic site in another, and you want to talk about the differences between these sites if that's of interest to you, and you want to compare clinics. Then you want the columns to reflect the responses that you got from each of these clinics, and it allows you to compare and contrast across the clinics themselves. One of the handy features of doing it like this is that you can integrate this with quantitative outcomes, the information that you collected through surveys, and really kind of integrate that with the kind of spoken in-depth information that you receive from your interviews or focus group discussions. And it's really helpful to vice versa explain the numbers, or for the numbers to kind of provide you more depth of of generalizability across the sample that you collected, or depth of understanding about that. So in this slide, we're going to talk a little bit about rigor and reflexivity. Rigor is an important element of most research. It is about maintaining standards or achieving certain scientific standards in the research, and rigor describes those standards and how to achieve them. In qualitative research, we apply trustworthiness standards to our data. These are three of the ones mentioned here. The first is credibility. You're trying to triangulate across different methods. So you have interviews and focus groups. Those both might reveal some evidence that points to something that's actually happening. Providers in a TB clinic might talk about stigma, and that same information that you're collecting from the providers within a focus group discussion setting, you're also collecting from providers through interviews. Now, you could also triangulate across sources. So not only is stigma, for example, something that providers are talking about, it's something that patients are also talking about within the clinic, and others within that setting that provide healthcare or allied health professionals are also corroborating. So you can really get credibility when you triangulate across methods, sources, and different levels. So, for example, if you take a hospital's infrastructure, we know that stigma is being discussed across the spectrum, across the levels, different levels in a hospital. It's the easiest way to think about it. Another standard is dependability. This is trying to keep a audit trail of any decisions that were made in the process of the research. Why a particular question was changed, for example, why a particular question was chosen, why an analytical decision was made in the process of doing your work. So this dependability criteria is essential in your conducting of rigorous work. Transferability is the last notion of rigor, last standard of rigor I'm going to mention here. This is really kind of getting us is often given through a thick description of context. So what do we mean by transferability? In qualitative settings, you have a small sample. Often you have just a handful of people that can speak to a certain particular issue. For example, if you're looking at policy around TB treatment in India, you only have a few policy practitioners that would be able to adequately provide you insights into that space. So the transferability from the India context to, say, another context somewhere else in the world, say Thailand, for example, would be more likely to happen through thick description of the context within which that occurs. One would imagine already that transferability when you're doing qualitative research is tough, but actually the provision of thick description of that particular context within which these conversations are emerging is of critical importance to ensuring trustworthiness in the research. Now, reflexivity deserves special emphasis in implementation work because researchers are often embedded in the very programs that they're studying. Sometimes you help design the thing that you're now evaluating. That closeness can bias what you ask and what you're able to hear. So name your positionality explicitly. Tell people, be honest about how your position in the program, your position in that particular setting shapes your access, your rapport, and your interpretation of the results or the findings. In implementation research, this isn't a formality. It's really, really important for people to believe your results if they understand your position in the project. Now, finally, I'm going to try to pull this all together into one kind of coherent design. So looking at the left side column, you frame the study with CFIR, right? That you create your study, you frame it using the CFIR framework. Then you plan your evaluation with the RE-AIM framework. You put together your formative interviews and focus group discussions on stigma and access and workflow. That's what you're interested in. Then you might sample purposively across high and low performing clinics, and you make sure to include both patients and those who completed treatment and those who disengaged. During rollout, then you'll directly observe therapy and run rapid interviews that feed back in real time. Then you might analyze with a framework analysis mapped to the CFIR framework, and so all the constructs in CFIR, building that clinic by clinic matrix that we had spoken about earlier. And the qualitative insight is what explains the completion numbers that you collected. The payoff is that your findings can adapt the intervention before scale up, and you end up with a single coherent mixed method story rather than two disconnected sort of data sets. So I just want to leave you with a few key takeaways here. Implementation science targets the no-do gap, right? What you know versus what is actually happening in the field. And TB is one really good case for this. We've talked about it throughout this talk. Frameworks give you structure, but qualitative methods give you meaning. They're what makes the frameworks real. Your toolkit that we talked about just now, interviews, focus group discussions, observations, they apply very directly to an implementation science setting. You want to sample across levels, collect across phases, and analyze with a framework. And keep reflexivity front of mind, especially when you're yourself embedded in the program that you're looking to study. So that's all I have for today. And thank you so much for the opportunity to have this conversation with you and for your time. These are some key references for any of you that might want to go deeper. I have included the DOIs here, so take a second to screenshot or take a photo of this slide. The foundational framework papers from Dan Schroeder, Glasgow, and Proctor. The methods pieces from Palinkas and from Hamilton and Finley on qualitative and rapid methods. You have Gale on the framework method and the TB-specific digital adherence work I've listed here. And hopefully these slides will be made available to you should you need them, should you need these references on hand. Again, I want to thank you all so much